Chairman, we're ready to begin.
Thank you, Denisha. And good morning to everyone. First of all, Denisha, would you please call the roll of board members?
Yes, Chairman. I'll begin with Norman Boyd,
Here.
Tommy Hopkins. Tommy Hopkins. I see that you're on, Dr. Hopkins. You may just need to unmute yourself. Cynthia Rucker.
Here.
Roger Folsom.
Here.
David Cruz.
Here.
Anthony Williamson.
Here.
Shane Mobley. Shane
Here.
Mobley, thank you.
Here.
Robert Coles
Here.
and Kathleen Ruth.
Here.
Chairman, that concludes my roll call.
Thank you. Thank you very much, Denisha. And with the roll call, we have 100% attendance today. Board members on Zoom and happy to have Dr. Ruth, our newest board member, join us here this morning on the call and be present here at the department. So appreciate that effort and effort of all of you taking your time to be with us today. We have a quorum to conduct business, as I said, so we'll officially call the meeting to order. Today we have an important subject and one subject only for the most part and to consider for vote, and that is our budget presentation and consideration of the budget, and we'll move into that after we start with the comments from Commissioner Carlson. So Commissioner Carlson, would you please take over?
Of course. Good morning, Mr. Chairman, Dr. Ruth, our board members attending virtually, and our fellow Georgians watching at home. Welcome to our second August meeting of 2024. As you know, we convened just 2 weeks ago in this very room to discuss several business items, but mainly to discuss the upcoming planning year for our state health benefit plan. And as always, the SHBP team is already out and about across the state for various outreach opportunities with active and retired SHBP members. And that outreach will only pick up throughout the fall as we prepare for the busy open enrollment season set to begin in October. We're very grateful for their service and hope everyone will continue to look at the SHBP website for a calendar of events so that our members can get educated and ask questions and hopefully somewhat close to home. Next week, August 27th, Lieutenant Governor Burt Jones will be hosting his second annual Constituent Services Day here in this very room, the DCH boardroom. We're honored Lieutenant Governor's office has again approached us to host. There'll be multiple state agencies here to assist Georgians with their various needs, whether it be health coverage, driver's license, anything in between. So please come by and see us then, or let friends and family know should they have any items they need to be resolved with the state. And speaking of outreach, I'd like to thank our DCH team, our DFAX colleagues, and multiple vendor partners for launching the robust campaign associated with Governor Kemp's Pathways to Coverage program. A new website launched August 1st, pathways.georgia.gov, along with a media campaign across both traditional media and newer technology-based modes of communication. Our teams have already covered events ranging from Dalton to Americus, not to mention multiple Metro Atlanta stops. From August until the end of the year, we've identified more than 80 community and back-to-school events across the state and have allocated staff and resources to have a presence at each. And we're open to more. We've established a mailbox designated just for Pathways events and outreach, and that is georgia.pathways@dch.ga.gov. georgia.pathways@dch.georgia.gov. As they say, no event is too small, so we ask the public to help guide us the best way to reach Georgians who may be interested in this free healthcare option for those who qualify. Again, the website is pathways.georgia.gov, and you can reach out to the inbox to help guide us across the state and reach people where they are, as they say. So now, Mr. Chairman, if I may quickly pivot to some employee milestones as we thank everyone for their loyal service to the state. Have a nice list for us today. I'll start with the 1 years this time, celebrating people who have reached their first anniversary in August here with the department. Ariel Lewis, Inspector General's Office. Tala Khalid, also with the General Counsel's Office. Kimberly Rogers, Georgia Board of Healthcare Workforce. Kenesha Sankey, Composite Medical Board. Alita Wilson, Financial Management. Nazia Abdullah, Division of Financial Management. Jacqueline Benjamin, SHBP. Donna Norman, HFRD. Mike Gombilgay, HFRD. Nicole White, HFRD. Sharon Brown, HFRD, and that's 5 years, Ms. Brown, 5 years. Thank you. Moving into 10 years, Shimmery Hodges, MAP. Shamika Ebron, Financial Management. Bridget Drumright, MAP. Valerie Sapp, MAP. Summer Lay, Project Management. Sandra Mason, Boards of Dentistry and Pharmacy. And Valerie Harrell, MAP. Again, those last 7 or 8 folks were meeting their 10th year with the department and the attached agencies, and we're very grateful for their service and don't take it for granted. So thank you for your willingness to be a part of the family and at such a busy time. So with that, Mr. Chairman, I'll hand it back to you for the agenda.
Thank you, Commissioner. Are there any questions, comments for the Commissioner from the board, please? Hearing none, we will move into the main subject of today's meeting, and that being budget of AFY 25 and FY 26 budget. And for that presentation, we've all received in advance from Denisha a copy of the presentation, had a chance to review it in advance, but to lead us through this, we'll call on Joe Hood, our Chief Operating Officer. So Joe, you may proceed.
Thank you, Mr. Chairman. Good morning, Mr. Chairman. Good morning, board members and Commissioner. Today, I'm presenting the board approval, the Department of Community Health's fiscal year 25 amended budget request and fiscal year 26 complete budget request that will be submitted to the Governor's Office of Planning and Budget for consideration in the upcoming Governor's budget request for the legislative session. The budget instructions were released to the department from the Governor's Office of Planning and Budget in late July. These instructions provided notice to agencies to maintain current spending levels. Therefore, what we will present today for changes for amended fiscal year 25 and 26 budgets are primarily our Medicaid growth changes that we anticipate through projection for the present year and then the upcoming year that will start July 1st of 2025. So we'll ask for consideration by the board at the conclusion of these budget request changes for those 2 years so that we can submit to the Office of Planning and Budget the complete request by September 3rd as provided in the instructions. With that, we'll move to the next slide. Remind us of our purpose, shaping the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. And then we'll move right into slide 4, which is our fiscal year 24 total expense by program. I'm going to spend a little bit of time here on this slide to explain the program and explain the structure, and the template is much the same as we go through the future years. We're starting with fiscal year 24 expenditures that have just ended by budgetary program to give a base understanding of how we have spent money throughout the year for each individual program and to provide a base comparison as we move to the next slide, which will be 25, and then eventually to the changes to 25 and the changes to 26. We think it's important for you to have an understanding of how we finished the year in order to have a true comparison as we move forward for our budget request. If you look at this slide, you'll see on the pie chart and the accompanying chart to the side that our Medicaid programs are our largest spend area. starting with our age, blind, and disabled population, which is the first program category. This program is in our fee-for-service program budget, which we primarily at the department manage and pay for claims through our Gamewell system for our Gamma system each year. You'll note that this is our highest spend area. However, this only represents, as you'll see later on our participation slides, approximately 18% of our total beneficiaries. That's due to the fact that most of these participants are elderly or older and have a higher acuity level or a higher healthcare need. So for example, this includes our nursing home residents and our waiver participants primarily that are in that fee-for-service population. Next, our next highest category for spend in fiscal year 24 is low-income Medicaid, and that's the second one that's listed there. That is primarily our women and children who are managed in our care management organizations. As you'll see at a later slide on participation, that is our largest participation group at 53%, but it doesn't really represent our true highest spend rate because those folks have lower spend, children and pregnant women, than you would expect the elderly to. And even though there's many more of them, that is one that's significantly less than the age, blind, and disabled total spend. The next program category is the Indigent Care Trust Fund. This provides funding that we receive from various places from provider fees and other sources to match our federal participation rate for Medicaid of over $1 billion. The next item that we have is the State Health Benefit Plan, which I skipped, I apologize. So the State Health Benefit Plan, of course, serves our teachers and our state employees with health care throughout the state, and it is our third largest budgetary program in whole. Next, we'll have departmental administration. I'm not going to spend much time here because I'm going to have a breakout of that on the next slide. After that, we have Peach Care for Kids, which is our next budgetary program, and that is indicated there at a smaller size and spend rate. Then we have the Healthcare Facility Regulation Division, which comprises all of the survey and oversight of all of our healthcare communities throughout the state. That would include hospitals, nursing homes, and any healthcare facility that's licensed by the state of Georgia, both state and federal. It's primarily dominated by the cooperation we have with the Centers for Medicare and Medicaid, and we have a great concentration on nursing home oversight and hospitals in that program. Also, as a part of healthcare facility regulation, we have as a subset our health planning unit, which oversees our certificate of need process and the needs planning to demonstrate what healthcare facilities we need throughout the state. The next item is healthcare access and improvement, and that's our Office of Rural Health, primarily concentrating on grants that are provided to us from the state and federal government to be distributed to the communities, primarily working with rural hospitals throughout the state of Georgia. And then lastly, within our department, we have the Board of Dentistry and Pharmacy, which is a consolidated unit which oversees those professions with the staffing for oversight and then licensure. And that concludes the amount that we have in total for fiscal year 24 by budgetary program. What we do not reflect here, because they independently have their own boards, are the attached agencies that the commissioner may have referenced earlier, such as Healthcare Workforce and Composite, and they have their independent budget presentations, which are not part of our consideration.
Joe, just so I understand the breakdown here, the Peach Care area covering children, but that's not all of the children that are covered under low income because they're also included in the, I guess, low income Medicaid. Is that correct?
It just depends. Yes, sir. That's absolutely correct. It depends upon where their eligibility is. And certainly from birth up to, I believe, age 1, they probably are in the low income Medicaid area with the new continuous coverage before there would be a potential conversion to Peach Care for Kids.
Okay, yeah, I just didn't want to have someone looking at these numbers and maybe perceiving that that's what we spend totally for low-income children, and it is not.
Right, and we'll have a slide that breaks out our participants later by program that will cover the percentage of each program to sort of indicate that.
Okay, thank you, Joe.
Moving to our next slide, we've got a breakout of our departmental administration. What we're trying to accomplish here is just to give context because of the large volume dollar that we have in administration. So the board has an understanding of what that truly represents on a pie chart basis and what the composition of that administrative budget is. As you can see from the pie chart and from the chart to the side, the largest component part of our administrative budget is contracts. And that's largely due to the administration of Medicaid. If you think about this, and it's not readily apparent to most folks, one of the largest component parts of that contractual part, 43% in fact, is to contract with our sister agencies, with the Department of Family and Children Services, with the Department of Behavioral Health, with the Department of Public Health, and those combine to equate to 43% or over $229 million of spend in fiscal year 24 for the staffing and benefits that they provide through services through those agencies that we pass through. They provide us the state matching funds, and then we draw federal funds to match their effort in regards to Medicaid and the services throughout Georgia. The next largest part of that contracts portion is our Medicaid providers that service our providers, really. It's the administration of Medicaid at the department through contract. That includes everything from eligibility that occurs in the gateway system to claims payment that we do through our Georgia Medicaid Management Information System to costing, compliance, pharmacy, and third-party liability. There are approximately 7 contractors in the administration of Medicaid that I've just referenced. And when you combine those, that is an additional 53% of that contractual line. So when you combine the sister agencies and the Medicaid primary contractors, that's 97% or over $500 million of our administrative budget that is spent on the administration of Medicaid programs that's in contracts before you get to the remaining part of administration. The rest of administration really flows from our staffing, as is typical with most entities. And you'll see our next item that's the most highest is personal services. We have a little less than 500 budgeted positions in administration that are reflected here in this cost effort with personal services. The remaining staff are in different programs that I referenced earlier, healthcare facility, which is a different program, Office of Rural Health, which is a different program. Those two combined to make up the difference on our staff, along with pharmacy and dentistry. All those positions are in different programs, but our core administration is a little over 500 positions. And then you have the typical things that follow below that. You have computers, operations, real estate rentals, and the like that support the personal services. So all told, that's how we have a total administrative budget that's over $600 million. But when folks look at that, I just want to make sure that the board and the public have the understanding that that's largely due to that contractual obligation to administer Medicaid and to provide the drawdown of federal funds to our sister agencies. Next slide. Next, we're going to review our 25 budget year by program. And this slide is very similar to our fiscal year 24 expenditure slide, except this represents the budget that is our base year budget that was passed by the legislature and signed by the governor in late May of this year that we started on in July of this year. So it is the same outline and basically a very similar allocation, but just not expenditures. This is our budget for the upcoming year. And the reason that we're presenting this is so that you can have a comparison of what we spent in 24 from the last slide, and then what we've moved to start the new year. And then when we get to our request, you'll be able to compare back to see what the request is by budgetary program to each individual item that we've presently been approved. Because remember, what we're doing today in the amended budget is to make changes by each individual program for expenditures that we weren't aware of at that point in time or had not projected by our actuaries that were going to increase or decrease, and how that impacts our overall budget. And so this will give you that comparison and that relationship as you go back in, if you want to review this in the future, or if the public wants to review it on the review. But overall, the programs are the same and we have the same allocation as we start the year. Next, we'll move to the beneficiaries by DCH programs. This is the slide that I was speaking of earlier, Mr. Chairman, that talks about the different percentages of benefits and how those are broken out. You can see that low-income Medicaid is primarily pregnant women and children. 76%, in fact, of low-income Medicaid is children. And then that's in addition, as you referenced, to the Peach Care for Kids, which is an additional 7%, which is children as well. So then the other aspects of beneficiaries that we serve are the age, blind, and disabled. As I referenced earlier, that's 18% of our population, but represents our largest spend area. And then lastly, of course, we have the state health benefit plan, which represents 22% of the participants that we serve on a whole when you're adding to 100% of everyone that's served by the department. And of course, that serves teachers and the state employees with health care throughout the state of Georgia. Next, we'll move to enrollment trends. What we're demonstrating here with enrollment trends with this slide that started back on the beginning of the slide in April of 2020 and moving forward is how this has changed over time and where we are today, which is really at the end of that beige point in time. If you see that right where the solid line ends and you start with the dotted line to start to increase, is really approximately where we are today, which is the end of redetermination. We have completed, for the most part, redetermination after the public health emergency and determined everyone who had not had an eligibility determination during the public health emergency. And that has brought us down to that low point as for the first time since the public health emergency, people have been removed or not renewed. Enrollment really drives costs for the most part. There are certainly other factors, and we're going to review the legislative ads that are a large factor of what increases rates or provides for new services, which are also a big component part of our request. But largely what I'm trying to impart for the public and for the board is that enrollment is what is really driving our budgetary request as a whole. And you'll be able to see that relationship as we go through the budget request changes for 25 and for 26. And you see we're at a low point now, but we project through the surge, the governor's efforts, where he has funded additional funding for overtime and for supplemental staffing to assist us in application and pathways and the like, that we anticipate that in 25 and going into 26, that we're going to have an increase in enrollment and a return really of an enrollment trend over that time frame. Next slide. This slide, which I'm not going to go over line by line, but certainly you can have for reference and we can go back and do question answers and the like, is a review of all the 25 legislative ads that we've implemented in this budget that were passed in past legislative sessions and signed by the governor, and then we've implemented them and they're in the 25 rate setting, either for low-income Medicaid with the CMOs, or they're in fee-for-service and reflected here. These have a significant impact upon our rates. So while enrollment may be going down or have gone down, we've increased with new services or with rate increases that in many times are significant in driving our rates depending upon the program that you're looking at. I'll just point out 2 or 3 on this slide to give you the understanding. If you look at the first 2, those represent over $500 million in total funds that are in the age, blind, and disabled population primarily because they're rate increases to our waiver funds. We spent quite a bit of time, and I know that the board is familiar with approvals that they had recommended that we submitted to CMS and now come back and been approved to be effective in July that increase those rates. And that's primarily going to impact our age, blind, and disabled request, as you'll see in a minute. The next one that is primarily on age, blind, and disabled initially, but also impacts CMO, is adult dental. This is a new service. It's the next to last on the chart there, and over 19 million in projected expenditures because we had not provided a complete adult dental coverage in our fee-for-service population prior to this point in time. And then that will be mimicked in our CMO population for those who require it. But again, that's going to have less impact there, as you recall, because mainly that's pregnant women and children who are in the LIM population. It's largely in the fee-for-service population that we expect most of this expenditure to occur.
Joe, just a point here. This reflects what was approved through the legislature, but also much of this had also, besides the legislature, had also come before this board because we've approved several things as a follow-up on increasing rates and provider rates and so on. So it's all reflected in this and summarized with those areas, right?
That's absolutely correct, Mr. Chairman. You should recognize almost all of these, if not all of these, have come before the board either through a rate increase or through a request for new service that then was submitted to CMS and approved to begin in July for this current year budget that we're in.
Thank you.
Next, we're going to move to the heart of our presentation and really what we're asking for approval for. And that the first one is our amended fiscal year 2025 projected budget request. And primarily, as I referenced in the beginning, we are only looking at our Medicaid programs because other programs are at a flat budget. We're maintaining our spend. That's the budget instructions. But we have to request changes as enrollment trends and other utilization impacts our Medicaid programs. So if you'll look at the very first column for ABD, or age blind and disabled, you'll note that this is the only one of these three in the amended that we have increases in per our request. And the reason for that is primarily because there was not as much of a significant change in redetermination for age blind and disabled. They are largely determined by Social Security for their disability and income. And it's a pretty stable population. It's our nursing home population and our waivers. And for that reason, there's not as much change on redetermination. There is some, if they've moved out of state or unfortunately they pass, we would have changes there that would occur. But because of that, and because of what I referenced on the prior slide for adult dental and for rates in waiver care and other items that are on that slide, we have an increase overall in growth of over $47 million. The other component parts of that are our nursing home increase, which I'm going to cover in another slide independently, and then our Medicare clawback. You may be under the understanding, but just for everyone's clear understanding, for Medicare, we have some participants who qualify for Medicare and Medicaid, and we pay their premium that is due for Medicare, and they call that Medicare clawback, to make certain that they maintain their Medicare eligibility, because that will pay approximately 80% of their claims for health care, and then Medicaid will be the payer of last resort in that instance. So that's the line item. We have an increase in those premiums for that population, and that's reflected there. Lastly is pharmacy spend. We've got increase in new pharmaceuticals that are available to age blind and disabled, and then we just have a general increase in pharmacy spend overall for that population. So you can see that totals up to our total request that will be a net positive for age blind and disabled. However, that's not the story when we move to low-income Medicaid, which is the next column. As I referenced, that's primarily pregnant women and children. And if you recall the enrollment trend and the participation slide, this is the largest part of Medicaid that we have on a member basis, 53% or better. And it truly is reflected largely the decrease here of $110 million due to that enrollment trend. And that's really only in fiscal year 25. As we move into 26, you'll see a change in that respect. The other items here are our non-claims, which are associated with that. So overall, we expect that we'll have $110 million reduction in limb in the present year. Moving to Peach Care for Kids, it's much the same. It's just a smaller population. The enrollment trend is driving that, and we have a negative projection there at this point in time for those two categories, limb and Peach Care for Kids. So when you net that all together for the amended year, we're going to ask for a reduction when we submit this initially to the Office of Planning and Budget. Now, I will say, and we're seeking your approval on this request, this is a point-in-time request. We will continue to monitor our enrollment trends. We get information on enrollment on a lag. So this represents basically the May enrollment trends was the endpoint for us for when we were doing projections forward. So as we move into the legislative cycle and work with the Office of Planning and Budget, there's potential that if enrollment trends change, particularly with the surge, and we're off in some respect, that we'll do adjustments with OPB and they will make further adjustments that's up to their discretion before the governor's budget comes out. The next item is the skilled nursing facilities, which was a line item on the previous slide for amended. And I just wanted to break this out and further explain that so the board has a true understanding. You may recall that we did a policy change in concert with legislative and governmental approval to update nursing home cost reports on an annual basis. Prior to that, we just did basically a cost adjustment of an estimate of what we thought had changed within that year. So we might say we're seeking a 5% increase or something along those lines. And we did that for many years. Now we've made this policy change that we're going to go to the most recent audited cost report that we have, and we'll renew that each year as we bring that forward. In doing that, we've incorporated that into our base budget, an estimate that's in 25, but we didn't have all the data at the time when that budget was passed. So now if you look at this slide, we have new information that has the projected bed days from 23 compared to 24. And we have an increase in utilization in the number of bed days for those years from what we were budgeted. And that net increase equates to that 17.9 million in state funds that we're requesting to cover what these new rates that went into effect July 1 will cost us in our present state fiscal year 25. And I expect that you'll continue to see this type of adjustment as we move forward in future budget years. Next, we'll go to our last item, which is our fiscal year 26 projected request by state funds. This is in the same format as we had for our amended fiscal year 25 budget, starting with age, blind, and disabled. You'll see here that, again, we have growth in fiscal year 26 for age, blind, and disabled, but we also have growth as the enrollment trend indicated in low-income Medicaid and Peach Care for Kids across that top line, for a total of over $335 million in increase due to claims that are increasing on individual cost of claims, as we talked about on legislative ads, and then also just due to enrollment growth trends. The combination is reflected in that amount. The next item is a reduction, and that is our federal participation rate. So as y'all are aware, we get a matching amount from the feds, and that's established based upon the state's income that's reevaluated by CMS on a regular basis. And then they tell us what that rate is going to be for a future projected year. And they have projected out that we will have an increase in what the federal government will pay for in our participation rate, or FMAP, in these future years for 26. And that means that we will have to reduce our state fund commitment, that we will have to match with a lesser amount. And that's the 49 million in reduction that you see across these three programs for that year. But we, again, on age, blind, and disabled, have Medicare callback premium increases that are reflected and pharmacy cost that we foresee as an increase. So overall, in fiscal year 26, across the three programs, we're estimating at this point a $347 million increase in state funds to match our federal drawdown for the fiscal year 26 that would start July 1st of 2025.
Joe, sorry, Mr. Chair, would you mind, and I apologize if you don't have it in front of you, no problem, but FMAP is so often referred to in percentages. Would you mind just sharing moving from what to what and effective, when that's effective?
I will have to follow up because
okay, no problem. Sorry.
It's a couple of decimal places though, to give some context. So it goes out, it's basically 3 to 1, and then the 2 decimal places will change slightly depending on, and that's what's happening here. And when that occurs, so we might go, and Cody, why don't you come up and read that, because you're going to do a better job of that than I am. This is Cody Whitlock. He's our Chief Financial Officer, and he's put on the slide the FMAP from a parking lot slide.
Good afternoon, or good morning. To Joe's point, it does change. So the federal fiscal year is actually starts October 1 through September 30th. So when we adjust it for the state fiscal year, we actually have to do 1/4 of the federal fiscal year and then 3/4 of the next federal fiscal year. So that's why you're seeing your blended FMAPs on that table on the right. So to your point, Commissioner, In FY 25, we're going from 66% to 66.35% is that slight adjustment, which yields that difference of the $20 million across ABD and LIM respectively.
Thank you, Cody.
Yeah, thank you, guys. Appreciate it.
With that, that concludes our presentation. If there are other questions, I'm happy to answer that or to ask for some help from Cody, and combined, we'll certainly answer the question. But if not, we ask for your favorable consideration for our amended fiscal year budget request for 25 and 26 by the board to be submitted to the Governor's Office of Planning and Budget.
Are there questions, comments from the board, please? I have a couple here, Joe. First of all, would you mind explaining now, if we vote to approve this, and then what's the process of this going forward in the timeline of which it is reviewed and becomes a final budget for 26?
Certainly. So the amended 25 budget, let's just take that separately.
Right.
That is one budgetary request for the budget that we are in now that started July 1. We'll submit that to the Office of Planning and Budget September 3rd. And then we will continue to have discussions with the Office of Planning and Budget, as I referenced, for any items that we feel that we need to seek budgetary change, but particularly on enrollment trends. And we'll update them as to what those enrollment trends are, all the way up to final budgetary submission for them, which is, Cody and I both were at the Office of Planning and Budget at one time, so we're familiar with that process. We call that going to print. And literally, that's what we mean. At a point in time, they will cut it off, and that is going to go to print a book. And you'll have, of course, the electronic copy now, which is largely shared, but they do still print to some extent actual books of that, and you lock it down. So there will be a point in time, generally after Thanksgiving, before Christmas, when that occurs, and that'll be the finalization of that budget. And then that'll be presented by the governor at his State of the State traditionally with highlights of that. And then it will follow in a joint budget presentation that is before the House and Senate Appropriations Committees, that the commissioner will come and present largely a similar presentation to this with updated numbers that reflects the governor's budget recommendation that has been submitted to the legislature. And we'll follow that process through the House Appropriations Committee, the Senate Appropriations Committee, answer their questions. There'll likely be changes on each side. They'll come together in a conference committee and make final determination of what the budget will be. And then it'll be passed and signed likely in late February, early March. And then we will have the benefit of whatever that change is for the last quarter, but many times it'll be reflective of the whole year, which is certainly the case for our Medicaid enrollment, right? Because we're looking at what it would be over the entire year. It's just we won't have that until that last quarter of the year for a final approval. Now, for the 26 budget, it follows the same process. It'll be presented in the joint at the same time, but then we'll have a separate committee hearing process in the House, Senate, and conference that will talk about that budget, and then it won't be effective until July 1st of the following year. And I don't want to leave out the last part. The last part of all that process is, of course, the governor has to sign the budget, make any considerations of details to the agencies of how he would like that to be implemented in both the amended or the big budget, and or remove any items that are not going to be approved and brought forward for implementation. And that's for the big budget. That's typically in late May for that effective date in July.
Thank you, Joe. Any other questions, comments from the board, please?
Chairman, I just have
Yes, Dr.
one
Reed.
question. So forgive me, Joe, if you've said this already, and thank you for your presentation, very thorough. The surge trend, so in taking account of the surge trends, will you have to come back to the board for another review of the budget to account for any changes?
That's a great question. So thank you for that. So no, what this is, the process is that we're going to submit our best estimate to the Governor's Office of Planning and Budget for their consideration and working with the governor. And then we'll continue to provide information to them, but it is up to the governor's discretion to make any changes from the information that we bring forward and his budgetary staff, and they will do that. And then they'll independently provide that to him and he'll approve any changes without further board approval. Now, at the very end, after he has signed a budget and we come back, there will be likely items in there that we did not contemplate, just like the legislative ads that I reviewed. And we'll individually end up going and approving those as a board to submit to CMS and to move forward for either the amended or the big budget.
Great, thank you so much.
Any other questions, comments? Hearing none, is there a motion for budget approval?
So move Hopkins.
Dr. Hopkins has moved for approval. Is there a second?
Second.
Folsom second.
Dr. Ruth and Roger Folsom have both seconded the motion. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved, and thank you very much, Joe, for your presentation. It was very, very well presented and detailed. Thank you so very much.
Thank you.
Does anyone know of any new business or things that need to come before the board at this time, or comments?
If I may, Mr. Chairman.
Yeah, Commissioner, please.
Yes, sir, Mr. Chairman, and I echo that. Thank you, Joe, and your team. It is it's really a real-time exercise with that lag. You know, you think about session where we are in January to where we are in late May. And as you could see with the, the FMAP slide, decimal points matter. So any changes in enrollment is really an interesting, it's definitely a real-time conversation. So as I thank Joe and Cody, the rest of the team, there's for all the work, and there are a lot of people who aren't here today that are part of that. I do want to go ahead and just call out one person that's involved in all this is Brian Lipton, who is now our strategic, and that's right, Cedric, you can zoom in a little bit more if you like to. In fact, I'd like you to, if you don't mind. Brian is his title changes, it's strategic finance, but at the bottom line is for all things policy and finance wise, he has been just kind of that invaluable Swiss Army knife, if you will, that I think anytime somebody was bumping up against an issue that they just couldn't quite crack, I think we all to Brian's quality of life, I'm sorry, we all had you on speed dial. But we're so grateful for what you gave to the state and at DCH and your years elsewhere. And we're happy that you're moving on some great opportunities that I know will benefit your family. You're a great loss, but I think we'll be collaborating with you a little bit moving forward. Joe and I personally miss you because you're a loyal dog fan that could line up as we prepare for football season. You're part of our front line there, but we got some others too. So, but Brian, thank you. What better time than after a budget presentation to say that, and with this being your last board meeting, I want to thank you for all that you've done for literally millions of people. So thank you, Brian.
We should appreciate those comments, and the board appreciates Brian's efforts as well. With that, if there's no other business to come before the board at this time, I'll just remind you that our next meeting will be September 12th at 10:30 back at the same location and on Zoom for board members that want to do it that way. And all have a good day, and meeting is adjourned. Thank you.